So welcome back. Because of timing, we will begin sharp 11:15. We have I'm sure, a great keynote lecture. A very good friend, very good colleague. It's not the first time in Switzerland. And she's from Sweden. She lives and works in the States, but she collaborates international. So Karin vare Silbernagel, the pronunciation exactly. She's professor and associate chair in the Department of PT at the University of Delaware. She's also the director of Center for Human Research Coordination there. Huge research activities and I don't know how many papers and really important contribution in the field of tendons. So Karin, you're welcome. Thanks you're here, and fasten your seatbelts now.
Thank you, everybody. I want to say, first of all, thank you so much to the organized committee for inviting me. It's almost like you get imposter syndromes with all these speakers around. It's been absolutely amazing to listen to everyone. And it's also really nice to see when you're thinking about all the different things and how we collectively is moving the research forward. I really enjoy seeing a lot of the younger researchers and enthusiastic, and there's a lot of things to do. So I'm very, very excited for where our field is moving forward, and having the combination of the sports physios and the sports docs, I think is really, really critical. Anyhow, I'm supposed to talk about tendinopathy, which has been my life for the last 20 years plus. These are my disclosures and funding sources. And as you get older, you start realizing you're ending up being like talking about history. But I really want to talk about the historical perspective too, from when I started. When I started, tendons was just something that attached a muscle to the bone, and that was that. And then I went into clinical practice, and everybody had tendinitis, which I understood from my medical terminology was inflammation of that tendon. So everybody had tendinitis in a structure that we never talked about. So we started to treating more of the word, right? So you're treating the inflammation. But then later on, we started to see that in like the late 1990s and more so, that maybe this was not an acute inflammatory process. So really we got from the paradigm shift from tendinitis, when we thought it was an acute inflammation. We had rest, ice, anti-inflammatory. We were very worried about doing exercises that was painful. And then when we realized maybe this is not an acute inflammation, we really had this paradigm shift. And I think that's why it's important to start calling it tendinopathy, which is the preferred term for the clinical diagnosis. And really what this shifted us into is that mechanical loading or exercise of the tendon is essential for healing. It's actually essential for the health of the tendon. And it's okay to continue to exercise despite having pain. And we can see some normalization or normalized structure when treated with exercise. And continued research, though, then maybe for the, kind of what is the perfect loading, and I might not ever get to that answer. But exercise as treatment is really have the highest level of evidence. This is what we need to do. However, the responses are varied, right? So, and it takes a long time. It takes 6 to 12 months, I would say, for somebody with tendinopathy, and we high recurrence rates. And I think what we're getting at when we started with the exercise, and that's why I have this kind of a hyper growth, I think when we went from not loading to starting to load, we had this hyper growth in our outcomes. All of a sudden, we're starting to see that these patients were doing so much better than when we were not loading. I think now that we are good at loading, we're getting up to this kind of saturation. Like, where are we now? How do we get, because, 80% of our patients got well from one study, others report 60%. A lot of people have continued symptoms. How do we get this last part to do really well? And what we can see is that maybe one size fits all is not correct. So we're looking at tendinopathy. Like, I focus on tendinopathy in the lower extremity, mainly Achilles and patella tendon, but it can occur in any tendon. And we see now increasing incidence in older, we see in adolescents, we see those with metabolic disorders, and we see a high recurrence rate. And we also see some reports now in Achilles tendinopathy has a negative impact on quality of life and healthcare costs, similar to knee osteoarthritis. So one other thing I want to point you to is starting to think about tendinopathy not as an overuse athletic injury, but more of maybe as a biological disease. And I have this up here because this is kind of what was pushed from osteoarthritis in the early 2000s, right? Like really, maybe osteoarthritis was not just a single disease, but many disorders with a similar final common pathway. And I would argue that maybe we're at the same stage for tendinopathy, and understanding this broader concept might help us get our patients better. So we really worked on the domains of tendon health is what we call it. And really when I work with athletes, I try to focus on, I want to keep your tendon healthy rather than focus on you might have an injured tendon or we want to prevent injury. I just want to keep your tendons healthy because healthy tendons, your performance is going to be so much better. That's going to make you from having a gold medal to kind of ending up in the worst 4th place, right, without a medal. So we kind of designed it on tendon health, looking at structure, which is what here, function, personal factors, symptoms, and psychological factors. And one thing I want to point out too, right, a lot of times when you're looking at clinical trials, it's almost always focusing on symptoms as the main outcome. However, sometimes our treatments might not actually be aimed at working on the symptoms, but it's aimed at improving structure to eventually improve symptoms. So just keep that in mind. And the timeline for recovery of the different domains is different. So I thought this was really brilliant, the tendon health domains, until Halli Sigurdsson from Iceland was my postdoc. He's like, well, what's your evidence for that? I'm like, well, it sounds good. So he really looked at our data. And you got to realize when you're looking at the research, right, the data is only as good as the measures that we do, but we try to have several measures in each domain. And if we put all of this data in and doing the analysis or a factor analysis, we really end up with 5 domains that are all uncorrelated, meaning you can have high in a lot of symptoms, but your function is not bad, or you can have structural changes, but maybe not that bad of symptoms. And this is starting to support that we need to thinking about this broader and measure different domains and not just focus on outcome or evaluating one domain. One of the things that I did not have in the initial first kind of domains, we kind of forgot about the personal factors in the sense. But really, I think that's really where we're ending up now too. And I'm going to talk a little bit more of our research on metabolic risk factors. But we are looking at hormonal stage. We do a lot of research now in female, looking at the hormonal cycle, how that affects symptoms. But we also have the age, and when we're looking at females and males, we don't see that big of a difference, but it might be more of an age and sex interaction. So there's a lot of things here that can be unpacked that we shouldn't forget. And I think we shouldn't underestimate this in elite athletes too. And I think you've heard it earlier today, like talking about bone stress injuries, thinking about other systemic factors that might actually be why this athlete is getting overused currently versus some other ones don't. I work a lot with the professional sports in the US too, and with the NBA, and here thinking about metabolic risk factors or thinking about prediabetes, thinking about nutrition and those things becomes really important. The other thing that I have the luxury to work with is Stephanie Cohn, who's an excellent biomedical engineer. She started now at University of Delaware. She was before at Wisconsin University for a postdoc working with Daryl Thielen. And they really have both 2 different kind of methods, but one is looking with MRI, really trying to understand more of the subtendons, meaning you have 3 muscles that goes into the Achilles tendon, but there's more and more evidence that each muscle has its kind of like its own tendon that kind of twists, but there might be differences in how this anatomy looks between different individuals that might relate to inter-individuals variability too. I'm not going to talk that much more about it, but we just got a 5-year research grant from the NIH. Can you believe you get funding in the US nowadays? But anyway, I don't think Achilles tendons are very controversial. But what stays in Switzerland, what says here stays here. Don't tell anybody. But we are really kind of excited to start understanding more of the individual variability here as well. I just want to put up here too, now Ito was a previous PhD student of mine, is now in Wisconsin. He actually, when we were looking at the patella tendon, maybe it's not as uniform as we thought either. So we actually see differences in thicknesses and tendon mechanical properties across the patella tendon that might relate to why you have injuries, maybe more at the midsection or some have more on the medial section. And maybe this is something we need to consider as we move forward with our treatment and exercises. So we have all of these outcome measures, and one of the studies that we did then is when you do research, you need a really good PhD student. I had Sean, and you really need a good biostatistician, and Ryan Polig has been the biostatistician that I worked with for many years. And what we did with all the studies or the data that we had is, are there subgroups of patients? Because I keep on talking about this variability in the different domains, but are there hidden subgroups that we can look with latent class analysis to understand how can we kind of find these groups? So what we did is we had this study ongoing, comparing men and women. We used our exercise program, progressive loading of Achilles tendon. We used our pain monitoring model to progress exercise. We have patient education and training diaries. And then we had 142 participants. And first what we looked at is kind of looking at these subgroups. And let me kind of explain how this works. You can see the different colors of the circles or the spiral plots are different domains. The dotted line is the average of all 4 groups. The further out you are in the circle, the more problem you have in that area. And the closer to the center, the less problem you have in that area. And what we identified was 4 different groups. The first one was an activity dominant, and this is kind of the younger, 68% identify as runners. And they seem to not have a lot of functional deficits. They had some structural changes, they have symptoms, but seem kind of fairly low changes. Then we have the function dominant, which is a little bit older, not that different from the activity dominant, but they have a little bit more structural, a little bit more functional changes. And again, about 68% of them are runners. Then we ended up with the psychosocial dominant group, which was more females. 31% was runner, but they had a lot of functional deficits with our testing. They also had really high Tampa scale of kinesiophobia, so they had a lot more fear of movement. And they had a lot of changes in quality of life and a lot of symptoms. And then the 4th group is what we call the structure dominant, was basically the smallest group. We had no runners in this group. They were older, mostly men, obese men with high BMIs. And they really had horrible looking structure of the tendons. They had functional deficits. Otherwise, they were kind of average in the other symptoms. So we had these 4 groups, which we're excited about because that really feels like a lot of times this is what we see clinically. And maybe starting to understand that maybe they need different things. And we heard a lot about it yesterday with back pain, thinking about the cognitive behavioral, and maybe there are some of these groups that need more of it, but not everyone. When we looked at the summary of the results for treatment up to 6 months, we saw only the activity and function dominant achieved functional recovery despite persistent symptoms. Psychosocial dominant reported greatest impairment of symptoms. Structure dominant had really delayed an improvement in both symptoms and were the only subgroup that did not achieve structural recovery. But no subgroup met the criteria for complete recovery in all domains at 6 months. However, satisfaction with treatment was really high in general across the groups. So I try to kind of paint this picture that there are subgroups, and that when you're a clinician, this kind of makes sense with the different people, and how do we pick what differences are? Just to kind of elaborate on that a little bit, we kind of looked at the data. This is not published yet, but like, okay, what's the difference between runners and non-runners? And the reason we use runners is because when they come into us, they identify, are you a runner or not? I'm talking about, are you doing running-related activity? And really about half of them were runners, half of them are not. But runners seems to have less symptoms, they don't have a lot of functional deficit, less structural deficit, and lower BMI. So for me, clinically, a lot of times we see with the athletes, maybe they don't have a lot of deficits, but maybe these are the overloaders. So maybe this is the group that you're not focusing on improving each domain, but you are kind of changing how they're loading and load control and using the pain monitoring model. The other things we've looked at is stage of tendinopathy. A lot of times, like it's an acute phase, subacute, it's a chronic phase. And we looked at with how long they have reported the symptoms. And we really did not see any differences in baseline symptoms or any outcome with 16 weeks with exercise relating to how long you've had symptoms. We've also looked at fear of movement, your level of kinesiophobia, and in general, people with Achilles tendinopathy score actually quite high on Tampa scale of kinesiophobia. But when we're looking at treatment over time, what we see, regardless of your initial level of kinesiophobia, you're improving at 8 weeks with our exercises. People with high kinesiophobia, they'll start with worse symptoms, and they don't catch up at 8 weeks, which we wouldn't expect. But the interesting thing, and this is with our exercise program with education and the pain monitoring model, the nice part is to see that the Tampa scale of kinesiophobia scores decrease in the high group to become more like in the middle or the lower group. So the kinesiophobia is changing with the exercise program. We've also looked at metabolic risk factors, and what we can see is, this one is published and we're looking at one over time, but people that have high risk of metabolic risk, cardiovascular risk, risk for prediabetes or diabetes, what we can see that the higher risk, or if you have 2+ risk factors, you have worse symptoms with loading, and you have smaller Achilles tendon relating to your body size and worse lower limb function. And this is something we're about to publish, where we submitted, when we're looking at the change over time, people with worse or have 2+ risk factors for cardiovascular risk, they are worse symptoms when they start. They keep on improving with our exercise program, but they don't quite reach the same levels at the other group that have less risk factors. So metabolic syndrome, I think, is something that we really see, and probably see maybe more in our sedentary individuals. So I think we can argue that tendinopathy, maybe we need to think about it broader as an enduring disease. And I think the reason that is important, it's partly because if you're looking for funding, it's easier to, right now, maybe get for osteoarthritis, looking at a disease. I think tendinopathy has the same. And I think it's really important then to understand when you're treating your individuals, consider the subgroups, and important to kind of align your outcome measures with the proposed treatment to kind of figuring out what domain is where they have the deficits. So I'm going to do in like the last 10 minutes here is like, what are the next steps, right? I've said the exercise is critical. Whatever you do, this is what you need to do. But how do we get to the next level? And I want to propose a few things here. One of the things is exercise has a rehabilitation, the highest level of evidence. And we talked about the mechanical loading or the strain of the tendon was really, really critical. When we're looking at the progression, one of the things that how do we know, we're talking about pain monitoring model to kind of control the load, and we're also looking at the progressive of the loading. And one of the things that we really try to think about then, how do we know that we're progressing? How do we know the load of the tendon? So we published 2 different studies to kind of help with that. One looking at the progression in Achilles tendon, and one looking at the progression in patella tendon that you can really look at to kind of find which exercise loads more than the next one. We've also looked at, can you do sports activity during rehabilitation? And this was part of my thesis way back when, but we used our pain monitoring model that you can have pain up to a 5 with activity but not higher to modify running and jumping activity during our rehabilitation. And what we saw was that even if you were resting with no activity or used the pain monitoring model for activity, we can see that both groups improved over time similarly. So we started to understand that limiting activity, and I think you've heard that with everything else, like stopping activity is the worst thing you can do. And now we know you can use the activity, the pain monitoring model to modify your activity to make sure we keep people active, right? We want to keep them active without overloading. And we've used this for patella tendinopathy with success in a pilot and a feasibility trial. And we've actually just working on it in pediatric with heel pain. And we see this kind of ladder and pain monitoring model works well in the pediatric with heel pain and Achilles tendinopathy. The other interesting thing is I think there's a lot of studies out there now looking at various exercise programs. And I love this one, comparing Alfredsson with the Silbernagel. Like, why would you do that? But anyway, we both do heel I kind of say this as jokingly too, but Håkan Alfredsson, who is a friend, he's from northern Sweden, his exercise program was twice a day. Our exercise program is daily. And then you have the Danish people that do heavy, slow resistance training 3 times a week. And I think the reason is because Håkan Alfredsson lived in northern Sweden. They have nothing else to do. They might as well exercise twice a day. I live in southern Sweden, and we have it nice, and I like exercising every day. It's good for you. And the Danish people are just really lazy, so they only do it 3 times a week. Anyway, I'm stand by that. But when you're starting to actually look at our different exercise program, I'm just going to click through these things, but comparing moderate to heavy loads with patella, we don't really see that big of a difference between the exercise programs, even though we assume that higher strain of the tendon with heavier loads will be doing better. So what is this? Why don't we see this differential? I mean, one argument I've made already is maybe we reach a saturation with exercises, right? Or are there other reasons? So this is leading us into, is the exercise doing what you think it's doing? And I think Nicola Maffaletti talked about, the muscle inhibition relating to knee injuries, but also when you have pain like in the Achilles tendon, and this is a study where they caused pain in the tendon, and really what you can see is when you induce pain, that you reduce the EMG activity, right, in agonist, synergist, and antagonistic muscles. And we can see widespread and reduced motor responses, right? So if you have this pain and you're telling somebody to exercise, are we really getting the load to the tendon that we think we're doing? So I was working with Angel Basas and Carlos Basas from Spain. Angel Basas was really known, we call it the Basa squat, right? Really the Spanish squat, using MMES for people with patella tendinopathy, and had some success with that too. When his son came to us to really working on this too. And what we really see is like pain causes muscle inhibition, right? And when you have patella tendinopathy, you're only using maybe 80 to 85% of your muscle capacity. And when you're doing exercise, you have great capacity to compensate. So what we did, we just looked at in healthy individuals, the Basa squat with or without electrical stimulation when you're sitting in the 90-90, and we evaluated the strain of the tendon with ultrasound imaging, basically the distance between the tibiotubercle and the distal pole of the patella to see if we can get differences. And we saw you got more strain in the tendon when you did the squat and added muscular electrical stimulation on it. So maybe you're getting more strain in the tendon using MMES. And we are working on this, looking at patella tendinopathy and patella tendon too, but I would still say, like even when we talked about the muscles earlier today, right? Don't forget about NMES. You can always find a pain-free position, and if you have atrophy or inhibition, if you use the NMES, you can kind of overcome that in order to get some loading to the tendon. And some of the benefits we've seen already is it's less, they feel better. It's easier to do in healthy with the NMES to get a good contraction. And people with patella tendinopathy and Achilles tendinopathy have less pain. So the other thing I want to talk about then too, so João Durigan was a visiting researcher from Brazil, and we were looking at this with NMES, looking at the Achilles tendon. And Stephanie Cohn then that I work with, they use what's called a tensiometer, which is basically a tendon tapper. So you can tap the tendon with this device, and then you can see the wave going through the tendon and how fast it goes. The wave speed relates to how much tension you have in the tendon. So we can use this, and we had this on the Achilles tendon. We have them in a HUMAC, prone, pushing the hard as they can, isometric. And when we're looking at the torque levels here, like you can see the torque for max voluntary isometric contraction, the first bar. The second bar is no voluntary contraction, only electrical stimulation. So we turn the electrical stimulation up as high as we can to get a contraction, and you can see the torque output. And then with 20% MVIC or 20% of electrical stimulation, you can see the torque output is the same. That's just to validate what we're doing because that's based on the MVIC. And what we can see is that we have about a 60% lower torque output when we're using electrical stimulation of the calf versus voluntary plantar flexion contracture. And then when we're looking at the wave speed, that will be the tension in the tendon, what we see here, that when you're doing the voluntary contraction versus the electrical stimulation, we only have 19% lower tension in the tendon. Meaning that if you're doing plantar flexion contracture, you have a lot of other muscles crossing the joint. You can have a lot of compensation. Even if you're going higher, in healthy individuals, you might not get more load into the tendon. So I think this is important to think about when you are doing somebody with pain and you think, I'm going to load it more. We've seen other exercise, when the exercises becomes complicated, you actually deload, sometimes the knee, you deload the tendon because you're compensating more rather than doing the lower load. So that might be why there's no difference between heavy and moderate loads. So in the last few minutes here, What about how you load the tendon during sports activities? And I just want to share some data when we're looking at Achilles tendinopathy and tendon compression, because tendon compression, when you're walking into more dorsiflexion, you have more tendon compression and strain in the tendon, which is kind of related to worse symptom and worse structure. And we did this then looking at kind of how do people walk with Achilles tendinopathy. And one of the hypotheses, we're interested to look at Achilles tendon rupture. They don't have pain, but they have kind of a lot worse structure. Achilles tendinopathy don't have that big of a change in structure, but they have pain, and then we have normal. And what we were looking at was looking at how do you load the Achilles tendon? And this is basically, the first graph is healthy tendon, the x-axis is percent of gait cycle, and then the y-axis is normalized speed through the tendon with the shear wave tensiometry. And what you can see, the healthy and the rupture is a little bit different, but side-to-side difference in the ruptures is not that big of a difference, or in healthy. In the middle one, you can see the darker lines there is from the painful side. And they have higher tension in the tendinopathy leg, probably due to avoiding controlling the tibia, but rather kind of not go over, going too much dorsiflexion, and right before push-off, you have all this tension in the Achilles tendinopathy. So I think what this is kind of showing you too, that maybe, you know, our pain, as you heard this morning when you're thinking about muscle inhibition, has greater effect of gait on the tendon rather than the structural changes. And we are therefore have done some studies looking at insertional, looking at focused on symptoms, and what we see, if we can just put heel lifts in people with Achilles tendinopathy, mainly insertional, that would actually take the pain off, and maybe the benefit of just taking the pain off, if you can start kind of contracting the muscle, and that's why we can see just in 2 weeks of using heel lifts, we see big changes. So I'm going to finish the last minute and a half to kind of slide us into the next presentations too, is like, what about adjunct treatments? Will that help? And again, I want to really emphasize that exercise is absolutely the key, but what about the last 20%? Or in athletes, is there anything we can do to make changes quicker? And I don't think biology can be altered or sped up, but sometimes I just feel like these people with Achilles tendinopathy, and I've said this many times before, is like, I just want to whack their tendon, because it feels like it's like a status quo when I want something to happen. So then I work with Adam 1040, who's a doctor at Harvard that does radial pressure wave, or he does shock wave too, focused as well, but he's like, you say you want to whack the tendon, but I actually do whack the tendon with radial pressure wave. Let's see if this makes a difference. So we had a study. These are purely runners, just to realize. So thinking about that this might be mostly the activity dominant, function dominant group. But we compared exercise protocol, and we used the protocol that I have, or the Silbernagel protocol, with the pain monitoring model for these patients. So one group just got the exercises, another group got exercise and radial pressure wave, three weekly sessions, and then we have exercise along with photobiomodulation. And I want to share these like in the last minute here, but this is the VISA scores by the groups. And what you can see in the baseline, they weren't very different. But at 3 months, it seems that maybe the group that got the exercise and radial pressure wave had improved a bit better than the other two groups. And again, the exercise groups did well, the other groups. So maybe there is something there to kind of go. So what I want to share, though, this is the results that I shared before when we were comparing people that can do activity or not. And what I'm excited about more so when I'm looking at this is because you can always show that something is better than exercise if you have a shitty exercise protocol. But really what we can see here at 3 months, the exercise protocol was pretty much very similar to our study back in 2007. And that makes me feel good that probably the exercises was doing what we were supposed to do, right? So at 3 months, we can see in our previous, we were around 75, 80 out of 100, and that was very similar in the exercise group when we looked at the radial pressure wave. But the radial pressure wave maybe helped to get a little bit higher early on, but maybe in the long term, we're starting to see in the data that we haven't published yet, they start to even out. So maybe there are things we can do to kind of improve a little bit and moving forward. So in summary, tendon needs loading to recover. Type of muscle contraction does not really matter, but progressive loading, knowing how to progress, using the pain monitoring is effective. Pain and tendon structure changes alters muscle recruitment and subsequent tendon loading. And I'm really back to the basics. I think NMES may help to increase muscle recruitment and increase tendon strain. And we use a lot of NMES now with the NBA, really thinking about the day after, when they talked about this morning, that how their muscle activity might go down, using NMES to get tendon load during those off days. And adjunct treatments, I'm curious to hear later on, might be beneficial. I want to thank everybody that's done the research with me. We're a really big group, and I want to thank you for all for listening, and thank you for having me here.